Yeah. Good morning to all the distinguished guests. Thank you for the invitation of the 34th Great Wall International Congress. First of all, let me say sorry for Dr. Su Pixiong's can't be here. My name is Zhao Jing, and today I'll represent Dr. Su to give the lecture. The topic is Chinese experience with hybrid coronary revascularization. The background of HCR. As we all know, CABG remains the gold standard strategy for multivessel revascularization, and most survival benefits come from lima to LAD anastomosis. However, about 80% countries are still from grade SVG, and PCI is available for multivessel disease too, but not suitable for complex lesions. So HCR has become a third strategy for patient with MVD. We can do lima to LAD anastomosis by mid-cap or with robotic assistance. And for the non-LAD lesions, we can do PCI to deal with them. HCR was first introduced by Angelini in 1996, published in Lancet. And there are some reasons for choosing HCR for MVD patients. First one, the lima to LAD bridge is still a golden graft. It has a great 10-year patency rate and can be performed by minimally invasive surgery. Second, the SVG patency rate declines with time. However, the PCI with death for non-LAD lesions have a better patency rate. About the guidelines, we can see from the 2018 ESC guidelines that HCR can be considered in experienced center in specific patients. And the 2021 ACC-AHA guideline suggested that the role of HCR as an alternative to multivessel PCI and CABG for patients with MVD involving the LAD remains unclear. Additional studies still needed. And for the 2022 experts' consensus on HCR in China suggested that we can carry out HCR in experienced cardiac center, and HCR can serve as a complement and alternative to traditional CABG and PCI alone. And about the indications of HCR, first one is MVD patients with or without left main lesions. These patients have severe LAD lesion, which can be solved by mid-cap, and for the non-LAD lesions, we can solve them by PCI. In the past time, for the patient with multivessel disease, and the LAD lesions can be solved only by bypass grafting, and other lesions can solved by PCI. We did CABG most. And for patients with MVD, and every lesions can be solved by PCI, but the procedure on LAD is difficulty. We did PCI most. Actually, most of these patients can be transferred into HCR. And the second, MVD patients who can't tolerate traditional CABG, such as patient can't tolerate median atherectomy or CPB, patients with history of pericarditis and non-LAD target vessels can't be identified clearly, and patients with porcelain aorta, and patients with lack of suitable conduit materials and etc. And the third, patient with ACS. We did emergency PCI in LCX or RCA lesions first. Then, for the LAD lesions, they still need bypass graft, so we can do staged HCR. And the contraindications of HCR. For the absolute contraindications include emergency surgery, hemodynamic instability, and patient who can't tolerate dual antiplatelet therapy. And the relative contraindication is difficult lima LAD bypass, and history of thoracic surgery, severe obesity, and patients who can't tolerate single lung ventilation. And let's see some clinical outcomes of HCR in China. This is a 10-year follow-up study from Fuai Hospital, we can see in terms of MACES rate, HCR was similar to OPCAP and significantly superior to PCI. And about the MACES rate group analysis, in high Euroscore 2, HCR was much better than CABG and PCI, and in patients with high syntax score, HCR was much better than PCI, but similar to CABG. And this is a 47 months follow-up from Beijing Hospital, which compared 33 HCR versus 70 TAR. It showed no significant difference in incidence of all midterm outcomes and the freedom of MACES rate between the two groups. And this is one of researches of our center. It is a 20 months follow-up study compared 151 HCR versus 151 OPCAP with MVD. The incidence of MACES are similar in these two groups. And about our experience of HCR, first of all is anticoagulation and antiplatelet strategies. In preoperative period, we use aspirin and low molecule weight heparin, and it will be continued, and terifibin is added in severe patients. Clopidogrel and ticagrelor should be stopped for at least 5 days, and terifibin for 12 hours before surgery. And in intraoperative period, after confirms the Lima to LAD bridge by TTFM, we give clopidogrel 300 mg through a gastric tube, and heparin is used before PCI to keep ACT equal or more than 205 seconds and maintained until the end of PCI. And for the post-operative period, in patient without indication of second atherectomy, dual antiplatelet therapy is initiated after endotracheal intubation is removed. And about the Lima harvest, we harvest it in direct vision or with thoracoscopy assist. And about the Lima to LAD anastomosis, we use researcher method. For the Lima artery bed, we wrap it down. This technique is remarkable and drainage and reduce the drainage in 24 hours after the surgery significantly. And let's see some typical cases. Case 1 is a one-stop HCR case. This is a 77-year-old female admitted with unstable angina. She was with history of hypertension, diabetes, and hyperlipidemia. BMI was 90.7 and syntax score was 31. Euroscore 2 was 3.52. And we can see from the preoperative chest X-ray and the CAG that the patient was with calcification in ascending aorta. And he was with left main lesions and triple vessel lesions. This is the CAG and TTFM during the operation. And we did Lima to LAD anastomosis in midcap and put death in RCA. The CTI of the first day after surgery was 1.62 and the ventilator support time was 16 hours. Drainage on the first day was 610 and post-operative hospital stay was 7 days. Case 2, still a one-stop HCR. This is a 60-year-old male admitted with an ST elevation myocardial infarction. He was with history of hypertension, diabetes, hyperlipidemia, cerebral infarction with hemiplegia, and depression. The syntax score was 32, and the Euroscore 2 was 2.64. We can see from the preoperative CAG that he was with triple vessel disease. This is a CAG during the operation, and we did the midcap and put death in OM. CTI of the first day was 1.58 and the ventilator support time was 70 hours. Drainage of the first day was 450 and the patient discharged from the hospital after 9 days. We did CAG after 4 years of this surgery, and we can see the lima bridge is still smooth. Case 3. This is a staged HCR. This patient is a 60-year-old male admitted with an ST elevation myocardial infarction. He was with history of hypertension, CAD, hyperlipidemia, and encephalopathy. The BMI was 24.5 and syntax score was 28. Euroscore 2 was 0.98. We did PCI first in RCA, and 9 days after PCI, we did midcap on LAD. The CTNI of the first day was 2.2, and the ventilator support time was 17 hours. The patient discharged from the hospital 7 days after. And these are the photos after the HCR surgery. We can see the trauma was minimally. And for specific MVD patients, HCR is a third alternative coronary revascularization method, which has good perioperative and mid to long-term effects. HCR has a certain learning curve, which is not a simple superposition of two methods. Cardiac surgeons and cardiologists complement each other to achieve a 1+1 more than 2 therapeutic effect. Thank you for your time.